Thank you, everybody. Here we go here. So I really want to thank Kathy and Philip for inviting me today. I'm actually a cardiologist at MD Anderson, and I help Philip take care of all our ECD patients here at Anderson. So I wanted to make this as informative and to all the patients here. So I hope that if you have any questions and if you see me later, if I didn't answer anything, please feel free to stop me, and I'll be happy to answer any questions about the heart and ECD. Okay. Is that better? Okay. So let's go ahead and get started. So there we go. Okay. Just a little delay, so I'll have to wait for that. So Erdheim-Chester Disease, as you guys all know, was first discovered in 1930. It's an infiltrate of lipid-laden macrophages and giant cells and inflammatory cells that involves a lot of different organ systems, including the long bones. So far that we know that mostly it affects, based on our studies so far, men. The mean age of diagnosis, in which all of you guys know is a delayed diagnosis, is around 55 years. It's very rare in the pediatric group, and as I mentioned before, it does affect multiple organ systems, including the cardiovascular system. So it affects the bone, the skin, the lung, and also the kidney. So I'm a cardiologist at Anderson, as I noted before, and I really had four main objectives today for our talk. One was to describe and illustrate the cardiovascular manifestations of ECD. Then I wanted to go over the signs and symptoms that patients with ECD may present with that we've seen here at Anderson. I want to describe how we evaluate patients here at MD Anderson with ECD, and then go over some treatment recommendations for the cardiovascular manifestations that we see. So first objective, again, was to describe and illustrate the cardiovascular manifestations of ECD. So to our current knowledge so far, up to 70% of patients may have cardiovascular manifestations from their ECD. It seems to be higher in older patients, with the mean age of us seeing heart involvement is around 60 years. Now there's different sites of involvement in the cardiovascular system. There's the thoracic or abdominal aorta, which we'll illustrate a little bit later, the renal arteries, which can be involved, and then different parts of the heart. So the pericardium, which is the sac around the heart, the myocardium, the actual muscle of the heart, the endocardium, which is the inner lining of the heart, and then the arteries that give the heart blood supply, the coronary arteries, and lastly the heart valves, which open and close, can sometimes also be affected. So the most frequent cause, the most frequent site of involvement is actually the thoracic and abdominal aorta. So I just want to walk you through this figure first so we kind of get an understanding of what's going on. So the heart's kind of in the middle where my arrow is. Actually, it doesn't show the arrow, but so where the heart is labeled is the where all the arteries and the valves would be. And then off the heart, you see something labeled the ascending aorta. From there, there's something called the aortic arch, and then this large vessel starts to go down into your body. And initially, it's called the thoracic aorta because it's in the thoracic region of the body, and then it becomes the abdominal aorta. And that's actually the spot that Erdheim-Chester disease seems to affect the most. So up to 2/3 of patients have an effect in this area, which is in the thoracic and abdominal cavities on the aorta. And sometimes it can actually completely sheathe the aorta. And one of the other papers actually termed something called a coated aorta, where the entire aorta is just surrounded by these cells. And we'll actually look at that picture of that later. So as you can see, the aorta actually is a pretty large vessel, and actually will give off branches to other organs, including the kidneys. And sometimes the arteries to the kidneys also get affected. And we'll go through an example of what happens with that. So here's actually an example of a coated aorta. So this is actually you kind of lying on your back, and then you get a cut through where the kidneys and the aorta are. And I really wish the arrow would work, but we'll just go to this one because this is actually a little bit better. So The heart is kind of on the top of the figure there, and kind of by the spine you see the aorta. And the dark gray area around the aorta shouldn't really be there, and that's actually all the cells that, are surrounding the aorta. And this is actually called the coated aorta. So here, as I'd mentioned earlier, one of the major arteries that comes off the aorta is actually the renal artery. And sometimes the Erdheim-Chester disease can affect the arteries there as well. And the arrow actually points to where the renal vessel goes into the kidney. And this can cause some clinical consequences, which we'll allude to a little bit later. Now here's another coated aorta where the arrow is. So you should only see that white part where the arrow is. All the dark gray around that aorta is actually all the Erdheim-Chester disease cells around it. And then the arrowheads on the right of the picture are actually the cells surrounding the entire kidney. So it can be a diffuse process involving the entire aorta and sometimes also the major organ systems. Now kind of moving on from the big vessels into the heart, ECD can involve the pericardium, which is most common, the myocardium, and the endocardium. Now when it involves the pericardium, there's actually a sac that the heart rests in. And usually the sac has about 15 cc's of fluid, which is just lubricant. But sometimes the sac can accumulate with fluid, which is sometimes thought to be due to the ECD. And this can cause something called pericardial tamponade, which can sometimes be life-threatening. Now in this study, they actually reviewed 37 patients who underwent either an MRI or a CT. And they found that about half of them had some kind of infiltration of the right heart. About a third of them had a tumor-like mass around the right atrium, and around 20% had infiltration of a part of the heart called the AV sulcus, which kind of divides the top part of the heart with the bottom. Furthermore, you can also involve the arteries. So all those vessels on the side you see on the right side of the picture are actually heart arteries. And Erdheim-Chester disease can sometimes cause infiltration into these arteries, causing chest pain and even heart attacks. We've taken care of patients here with that. While we haven't seen this at Anderson, it's also been reported to cause problems with the aortic and mitral valves, which is on the left side of the heart. But I haven't seen that in my experience so far at Anderson. And lastly, it can actually involve the electrical system of the heart. So we've actually had a couple of patients who we suspect, because of their Erdheim-Chester disease, which was very involved in different parts of the heart, that may have gone to the electrical system of the heart, and they actually required pacemakers. So here's kind of what we had talked about earlier in figure form. So on the very outside where the 3 stars are, that's actually the pericardial effusion. It shouldn't be there. There should be nothing there. Where the arrow is actually a mass of inflammatory cells, and it's right between the right ventricle and the right atrium, which are labeled as RA and RV. And that's the pseudotumor mass that has been described by, I think, some of the other physicians here today and over the last few days. So in this picture, we actually see 2 things that sometimes a patient can have, the effusion and also the pseudotumor mass. Now here's the fluid that I was talking about earlier. So all that white that you see surrounding the heart shouldn't be there. Usually that sac has maybe 15 cc's of fluid. If you did an MRI or a CT on this patient, you shouldn't really see any white. So this patient probably had a few hundred cc's of fluid, which had to be removed. And it was thought to be due to ECD. As you can see on the cross-section image, which is labeled B, the amount of fluid there is probably just as much as the mass of the heart and the amount of fluid inside the heart. So this can sometimes become a life-threatening situation that needs immediate, urgent medical attention. And we'll talk about how we take care of that a little bit later. So the second objective I wanted to go over was what kind of signs and symptoms to look out for in patients with ECD. So these are some of the things that we've seen here at Anderson. These aren't all the symptoms that you may present with, but we see hypertension with our ECD patients. We've had patients come in with chest pain and also heart attacks that required stenting. Sometimes patient presents with heart failure symptoms, which would be shortness of breath or swelling in your legs or in your abdomen. We've had patients initially describe dizziness with walking, and sometimes frank syncopal episodes where they pass out and were found by their family members and brought into the hospital. And we've also had patients who just complain of palpitations or feelings of their heart racing. And those are the things when they come to my clinic that I need to evaluate on an urgent basis, and also think about, could these be potentially related to their ECD, or is it completely unrelated, which sometimes is the case as well. So hypertension, a lot of people have hypertension. They come into the doctor and they get a pill and it gets better. But with ECD, it might be a special case of hypertension. So as I mentioned earlier, sometimes the ECD can infiltrate those arteries that go to the kidneys. And if it does, it causes a special kind of hypertension called renovascular hypertension. And some medications may not work. Some medications actually may make it worse. So if you don't think about that process and don't get screened for it, you might be mistreating the patients. The other things that people present with is if you have coronary artery involvement, which is the arteries that supply blood flow to all the heart, you could have chest pain. We had a patient where their ECD was on the right side of their heart. It completely blocked off their right coronary artery, and they had to undergo emergent stenting to prevent a large heart attack. Sometimes patient presents with shortness of breath, and that might be due to that large effusion that we saw around the heart. And sometimes when we haven't seen this, but it's been reported in the literature, there have been some cases where the ECD was thought to affect the aortic and mitral valves, and patients got short of breath and started retaining fluids. There's been a few cases of what's thought to be ECD-caused valve issues requiring mitral valve or aortic valve replacement. So we went over the first two objectives, and thirdly, I wanted to kind of describe how we take care of the patients that present to our clinic here at Anderson. So, a lot of this is done actually before they even get to me. Philip and the rest of the oncologists and doctors taking care of our ECD patients do a great job of doing comprehensive imaging studies before they even get there. But, we do recommend that a comprehensive cardiac evaluation where not only the doctor seeing you, but having studies such as PET scans, CTs, MRIs be done to understand the cardiac manifestations of ECD. And the other point I'll make about this is you kind of have to know what you're looking for too. If you don't know what ECD causes, then it's hard to sometimes diagnose. So understanding what parts of the heart are involved and what to look for makes the job a lot simpler for our radiologist and our cardiologist or oncologist. And then lastly, the thing I wanted to point out was you might do the complete evaluation and you might find something, but it may not fit with what the patient's really complaining about. So look a little bit deeper. So if there's something that's not really evident to you, you may need to corroborate that with more testing rather than thinking it's not related to your organ system, perhaps the heart. So the example that we got was, and I don't see, I saw John earlier yesterday, but one of my colleagues had gotten a patient with palpitations, and they did all the testing and everything was normal, and later on they discovered that it was ECD, and they gave me a call. It was actually the weekend when they had come in, so I was like, okay, they have ECD. Let's look a little deeper. They had no problems really, other than feeling that their heart rate was a little fast. So I was like, put a Holter monitor on them. So about 3 days later, his wife calls me and says that he's having a lot of palpitations, is feeling dizzy. So I was like, well, send the Holter monitor to me, and he's having long pauses where his heart was just stopping for 4 or 5 seconds. So he never actually passed out. What I told the patient was, thank God we weren't driving when that happened, and we caught it early, and we put in a pacemaker. I think the very next Monday, we saw the abnormality on his heart rhythm on a Saturday, and on a Monday he had a pacemaker, and potentially prevented something bad from happening. So when I see a patient, like, these are the standard tests that I usually do depending on symptoms and what the consultation was for. So they all get ECGs, and this is to look for arrhythmias and heart block and also cardiac intervals. Some of you might have been on medications called, one of the medications is called vemurafenib, and that can prolong one of the intervals, specifically the QT interval. So we always do a baseline ECG, especially in those patients that are taking that type of medication. I personally get an echocardiogram in all patients. Most people get MRIs on all cardiac and all ECD patients with cardiac involvement, but I get echocardiograms as well, specifically because I think it's the best functional assessment for the heart valves. Most of the times, most of our patients have CT, MRIs, and or PET scans for disease localization, the degree involvement and progression, which will be repeated, sometimes every few months. And now if they present with any kind of chest pain, I usually proceed to a stress test or sometimes even a heart catheterization to see, A, is it related to the ECD? But the other point I'll make here is sometimes chest pain has nothing to do with the ECD at all. It might just be coronary artery disease, because coronary artery disease is the most common cause of death in the United States. So it may have nothing to do with ECD at all, but you still need to get evaluated and treated for it. It could be due to the ECD, but it's sometimes not. And then lastly, cardiac monitors. So if you have any kind of symptoms where you're dizzy or lightheaded or having palpitations, when we actually wear a monitor, it looks like a little pager you actually just wear under your shirt. A lot of my patients sometimes are, they go to work, they don't want anyone to know that they're wearing a monitor, but these monitors are small, they're hidden underneath your shirt, and nobody knows that they're there. And with technology now, you don't have to even have to drop off physically the monitor or pick it up. You can actually electronically transmit the information. There's actually a couple companies that will automatically wirelessly pick up the information and send to the doctor immediately. And the doctor will actually know real time as you will be having your symptoms and know what to do about it. And we've done that before. So lastly, we've gone over the first three objectives. I wanted to know what, most importantly probably, is what are the treatment options for the symptoms and signs that we've talked about. So the first thing I'll say is, like, they've got to be goal-directed, right? We want to make you feel better. We want to improve the symptoms. And then secondly, we want to try to reduce those symptoms from happening again. And sometimes that needs both comprehensive and repeated clinical evaluation. I underline repeated, but because sometimes it's not apparent in the beginning. So you've got to repeat sometimes a clinical evaluation to really get it correct and understand what's going on. And most doctors make their diagnosis clinically. That means you talk to the patient, you have your clinical acumen, you decide. But sometimes in ECD, you really do, it does really help to have some imaging studies as well to kind of tie the diagnosis together. So we work with, our clinical training and all the imaging studies we have together to help treat our patients. So hypertension. So if you went to, a primary care doctor, like my dad has hypertension and got some medicines for it, it's a little different with ECD patients because, like I mentioned to you earlier, there might be some involvement of the renal artery. So you probably should be screened for renal artery involvement. Sometimes there's different ways to screen it, sometimes an ultrasound, sometimes an MRI, sometimes an angiogram. And then there's been reports of, in the literature, we haven't done this at Anderson, of renal artery stenting to improve hypertension in patients who had ECD involvement of their renal arteries. Now, we've actually had some experience with this here at Anderson, but coronary artery involvement. So we've had patients come in with chest pains and actually heart attacks, and they've proceeded to coronary artery stenting, where we had to put in stents in the artery. And we treat them with the same medications that would be treated in anyone with a stent. There's been some reports of bypass surgery in the literature, none here at Anderson so far. And pericardial involvement is all the fluid around the sac. Now, this can sometimes be dangerous, and you have to remove the fluid pretty quickly if it is because it can be life-threatening. So usually here we do a pericardiocentesis where a small needle is inserted to that sac, or we do a controlled operation with anesthesia to remove the fluid around the sac. We haven't done this, but there's actually been a minimally invasive procedure described as well with robotics to remove that fluid around the sac as well. And that's been described in the literature. Now, heart valve involvement, if it's serious enough and it causes shortness of breath and swelling in your legs or your abdomen, which we describe as heart failure symptoms, can sometimes lead to valve replacement. And then we've had experience with this heart rhythm abnormalities. We've had to do pacemaker placements in a few of our patients here. And sometimes patients will have and irritation of their electrical system because of the involvement of the ECD, specifically to the right side of the heart. And it kind of triggers heart rhythm problems that tend not to go away unless you actually take care of the actual issue with the heart. So think about the heart as a bunch of electrical connections. And if you have an infiltration of these electrical connections, they begin to misfire. And they continue to misfire until you do something with it. Sometimes you can use medications, but sometimes we do ablation procedures where you actually take little catheters into the heart and then try to either freeze or burn that part of the heart to basically eliminate those electrical connections that are misfiring. It takes a while to actually do it. We actually use a big computer system to map out which part of the heart is actually causing the issue. So you're kind of looking for a needle in the haystack. So once you find the needle, it's easy, but sometimes when you're looking for it, it takes a while. So in conclusion, ECD has a myriad of cardiovascular manifestations that we see here at Anderson. We use both a comprehensive clinical and a multimodality imaging evaluation for our patients with ECD. And we can offer a wide range of treatments for patients who are ECD to both improve your symptoms and decrease further symptoms and cardiovascular complications with that. And with that, I'd like to thank everybody again for their time, and really do appreciate the opportunity to talk to everybody.
Now, does anyone have any questions for Dr. Hassan? Okay.
For about, I don't know, 8 years or something, I got diagnosed with ECD this year. But for about 8 years, I've carried nitroglycerin because I can just be sitting down ignoring life, and all of a sudden I get chest pain. And after about 10 minutes, I'll take a nitroglycerin, and it goes away immediately in a minute. So at one point, they looked to see if I was actually having esophageal spasms or whatever. And you know, I've had workups and stuff. I've never had a catheterization, but and there's a lot of heart history in our family. My dad had his first MI at 32 and died at 38. So
yeah.
And I have high blood pressure and stuff like that, but nobody's ever figured it out. They just said, well, just take the nitro.
Yeah. Have you had a stress test before?
Yeah.
They probably did a stress test. So sometimes, so there's really two questions. One is it the heart, right? And then the second question is it the heart, and does it have anything to do with ECD? That's just two kind of separate questions. So I'll tell you this. So if it's the heart or not, most chest pains are not the heart. That's if you just took a bunch of people. Most chest pains aren't going to be the heart. Now that doesn't give us solace, because let's say you have 100 patients, right, who have chest pain. Let's say 85 of them had non-heart related chest pain and 15 did. If I didn't screen any of them, then I just missed 15 patients that really had the real thing and I need to do something about. So usually the first step is stress test. Now if someone continues, in my practice, if someone continues to have chest pain and I don't have a diagnosis, then the gold standard test is really a cardiac catheterization. So you just go and look. And if you don't find anything there, then you could still have chest pain from the heart, because think about it this way. There's some major arteries, but then all those arteries branch off into smaller arteries, which you may not see the blockages in. So it's actually called microvascular disease. So the vessels that are so small that you don't really see on an angiogram, but they might be still causing chest pain, and sometimes people medically treat that with nitroglycerin and so forth. So there's still a potential. I mean, could it have nothing to do with the heart? Yeah, it still could. The stress test, on average, if you just took everybody, and this is not ECD patients, they're probably 85% to 90% accurate. So 10% of the time they can call something that's not there, and then 10% of the time they can miss something that is there. And we know that as cardiologists. So usually if they continue to have chest pain, and it really depends on the quality of your chest pain too, right? So if you're having exertional chest pain, which means I walk and I have chest pain, that makes me more worried. And if it's just kind of out of the blue and there's no really risk, there's no association with other symptoms that are classic, it could be that too. But it's something that, you know, I kind of stressed that earlier, like repeated evaluation. Sometimes you kind of have to keep on looking a little bit more. I don't know if the right answer is doing a cardiac catheterization, but there's other ways they can look for coronary artery disease, which would be the most common cause of chest pain. They could do a CT scan looking for calcium in the arteries. they could do the gold standard stress test, which is actually a PET cardiac stress test. If that one's normal, then it's pretty hard to have significant heart disease causing chest pain. So there's other tests we can look. It's hard to say exactly what it's from, but there's other tests that can look.
Thank you. We have another question right here.
I didn't notice you mentioning atrial fibrillation. Have you not come across that in connection with ECD?
No, we actually have. So actually the same patient that had the pacemaker before that had atrial fibrillation as well. We've had patients with atrial fibrillation, and it can happen. My personal feeling about it is it's probably from mass effect on the atria itself and irritating the atria. We actually see that a lot in cancer in MD Anderson here. MD Anderson here. I'll give you another example. So one of the other things, we're actually a sarcoma center. So one of the tumors that goes to the heart is sarcoma. And if it's in the right spot in the atrium, it also causes atrial fibrillation. So I think it might just be from the effect of the ECD cells being adjacent to the heart, so maybe pushing in from the outside, or perhaps, and it's hard to do this unless you actually have a heart tissue diagnosis, does the ECD go into the actual electrical system of the heart too and interfere with that? And that you'd only be able to do kind of on an autopsy sample later on, obviously. But that's my suspicion that in the patients that we had, that probably the ECD may have had something to do with it. Now, I'll play devil's advocate to myself, though. Atrial fibrillation is the most common irregular heart rhythm that we see. Millions of Americans have it, right? So were you going to develop it regardless of your ECD? It's really hard to know. Treatment's pretty much the same. If it becomes more resistant to treatment, then we would consider other things. But the treatment usually it ends up going down the same process.
Sorry, doctor. I'm just wondering, have you seen increase in blood pressure bouncing around the place? That's the easiest way to turn it. So you go from high blood pressure to low blood pressure. This is on dabrafenib, which is one of the, like venirafenib, one of those inhibitors. My blood pressure I'm on a blood pressure medication, and then basically I can, especially after eating or something like that, my blood pressure can just drop drastically down to 90/45, and I end up hitting the pavement. So where do we go with this, or have you any theory on the cause of it?
Yeah, we actually see that. I see that a lot in my practice, and with other targeted therapies, not just for ECD, but in general. There's probably, I don't have a scientific explanation, and I don't think anybody does at this point, but we see a lot of it. My kind of personal thought process on that is, and this is not just for ECD patients, is a lot of our targeted therapies, a lot of those patients have gone through other chemotherapies, and somehow those chemotherapies may have affected their autonomic nervous system, which helps kind of regulate your blood pressure. So you get these large swings. One of the drugs that we see, like you mentioned, are the tyrosine kinase inhibitors. That you get these large swings in. Usually what I try to do, and I'm sure your physician may have already tried to do as well, is if you're on more than one pill, and are you on more than one pill or just one? It's a dual pill. So usually what I do is I break up the pill into just single drugs, and I break them up during the day too. So, for example, it might be if you're on 25 milligrams of metoprolol twice daily, and another pill in the morning. What I would do is actually tell you not to take the morning one in the morning to prevent maybe two medications acting at once and taking one in the middle of the day. The other thing I've gotten good feedback from is taking your pills right before going to bed. So you get the effect while you're sleeping. When you wake up, it may be wearing off, but at least your blood pressure is in 97/50, or you're down. But yeah, very low, causing symptoms. But it may have something to do with the drug, but it may have to do with the autonomic nervous system, which may have been affected by not only that drug, but other drugs from the past. We've had that's actually a big problem at Anderson. We probably have hundreds of patients like that, and it is hard to deal with. There's no magic drug that gets rid of it. Some people are so bad they can't stand, They get that dizzy and lightheaded, and they can't stand. There's a little bit of literature on a specific medication called clonidine that they've used for something called orthostatic hypotension. You know, in my experience, it's probably like, the literature actually says it's about a 50-50 chance that it would work, but in my experience, it's more like 10% work and the other 90 don't. And they may have tried that before too. But yeah, I have tons of patients that have that same complaint, and it's hard to deal with.